That is why allergic reactions are much more severe at night than in daytime. And most of the allergic diseases are more prevalent or more severe at night. The patient has all these IgG antibodies against milk, wheat, and all that type of stuff. And when you do not know how to interpret it, you will say to the patient, you're allergic, you're producing antibody against all this, so you eliminate all these foods. Late phase reaction do not respond to antihistamines. That is why we use inhaled steroids. So when you are using inhaled steroids, what you are doing, you are taking care of the late phase reaction due to allergy. Histamine is the one that causes itching. Histamine is the one that causes mucus production.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Good evening to all of you. I'm Dr. Vedanthan from Colorado. Originally I'm from Mysore, India. And I come to India every year to run several programs, training programs. So I spend almost 5 to 6 months in India. So my assignment today is to talk about what is allergy, some basics, and how do you clinically approach it. Next slide. First of all, what we need to know is allergy is a very old disease, but with a new explanation. The first reported reaction happened almost 5,000 years ago in the Egyptian pharaoh Menes, when he was having his congregation. He was an able-bodied young man. The ministers saw that he suddenly collapsed, and someone also had noticed something had bitten him and flew off. So they knew it was some sort of an external agent that caused this issue. He had an anaphylactic reaction to an insect sting and he died on the spot. So there was no explanation of this situation until only recently, in 1968, we knew what it was. That Pharaoh had IgE antibodies against insect venom, and that's what caused the anaphylactic reaction. If you take the history, the most important event was in 1921. Prosnis and Kushner, two French scientists, showed that there is something in the serum of a patient with allergies that could be transferred to another individual who did not have allergy. That is called passive transfer. And that is when they named it as reagin. Coca and Cook in 1923 coined the word atopy, which we use, and I'm going to talk about it in a second. It was only recently, 1968, at the same institute where I did my fellowship in Denver, Colorado, IgE was discovered by the Japanese couple, Ishizaka couple. Very hardworking physicians and researchers, Teruko and Kimizake Ishizaka, discovered IgE. Why did it take this long to discover IgE? Because it was more of a technical issue. If you look at the lab reports, most of the immunoglobulins are reported in milligrams, whereas IgE is reported in units. Actually, it is present in micrograms. So there was no technology at that time for us to measure in micrograms until the Ishizagas figured it out. Johannesson, on the other hand, the next year in Uppsala, Sweden, had a patient with myeloma, B cell myeloma, producing huge amounts of IgE, which was floating in the serum. It was very easy to detect it. So that patient actually sold his serum to many companies, pharma companies, and became very prosperous. So that is how the discovery of IgE, what is E, a substance that produces erythema, redness, was discovered 1968. For until then, people used to deal with allergic reactions, but without knowing the mechanism. For the first time in 1968, which is only 57 years ago, immunology entered the field of allergy. So for the first time, we came to know this is an immunological reaction. It is not a reaction that somebody is imagining in his head. So a very simple definition is it's an exaggerated immunological reaction, and it is directed against very benign substances, harmless substances. And actually, it is sort of a protective phenomena, but the protection is so strong, it causes harmful effects, and that's what causes the tissue damage. So it is an exaggerated immunological reaction to commonly found harmless substances. Some of the harmless substances people get sensitized to are all around us, like dust mite, cockroach, cat, dog, pollens, several common foods. Most of us don't even pay any attention to them, but an immunological system in an allergic reaction, in the allergic individual, pays a lot of attention to it 24/7, even during sleep. So when you are sleeping, when your eyes are closed, your immunological eyes are open. It's actually at a much heightened sensitivity at night. Our immune system are at much heightened sensitivity at night than during daytime. That is why allergic reactions are much more severe at night than in daytime. And most of the allergic diseases are more prevalent or more severe at night, which includes allergic rhinitis, asthma, eczema, food allergy reaction, drug allergy reaction. Everything is more severe at night, and that is chronobiological phenomena. Now, we use these terms very commonly. These are interchangeable words, but actually they should not be. We use the word, oh, that person comes from an atopic family. What atopy strictly means is you're genetically wired. You're wired to have the allergic mechanism that can be triggered anytime in you. So you are genetically prone to develop allergies. You may not have any symptoms, you may not even have sensitization, but you come from that family. My brother has allergies, my uncle has allergies. So maybe you're wired, and that is called atopy. Atopy is a genetic state. Sensitization is where your immune system is exposed to the allergen and it produces IgE antibodies in response to it. I'll show you the mechanism in a minute. And that is an immunological state. Your body has produced allergic antibody, which is IgE antibody, and that is when we say you're sensitized. But allergy is a clinical phenomena. It's a clinical state where you start having symptoms due to the tissue damage. Because of the antigen antibody reaction, there is tissue damage, lot of leukotrienes, a lot of interleukins, of several substances are produced by your cells and system and causes tissue damage. Interleukin 4, 13, so many of them. And that is allergy. So summarize, atopy is a genetic state, sensitization is an immunological state, allergy is a clinical state. You need to understand that you can be sensitized but not allergic, which means you can have positive skin test, or even hooked onto your muscle, but you may not have any symptoms. Say like you're 100 of you, I skin test all of you for dust mite, and I find that 75 of the 100 will react to the dust mite antigen. That means you're 75% sensitized, but only 30 of you will have symptoms. That means 30 are allergic. But out of 100, maybe 90 have atopy. They have family history. So family history is atopy, his genetic state is atopy, sensitization, immunological state, allergy is a clinical state. This should be very clearly understood. That is why I am repeating it. Now, what is a defect in an allergic individual? People always think IgE, IgE. That is not so. Allergy is a classical gene environmental interaction disease. An allergic individual, or even an atopic individual, or even any sensitized individual, the epithelium is weak, the skin is weak, mucous membrane is weak. The generally in a normal individual who does not have any such histories or symptoms, a non-atopic individual, non-allergic individual, his skin is very tight. Okay, the skin or mucous membrane, the epithelium, is sewed to each other in several ways, to the basement membrane, to each other by hemidesmosome, desmosomes. Then you have all these different apical junction and several types of material are sewed to each other. So the epithelium is very strong and tight. Same thing is mucous membrane. And so in allergic individual or atopic individual, the epithelium is weak, it's compromised. So when you have a weak epithelium, when the environmental agents like allergens, pathogens, pollutants are floating around, they enter through the skin, they enter through the mucous membrane. And in the dermis, you have the mast cell, you got the immune cells and all that. And that is how interaction takes place. So allergy is a classical disease of gene environment interaction. Let me close the door, I'll be back. So this is something I already have mentioned to you, that when you're atopic, that doesn't mean allergy. When you're sensitized, doesn't mean allergy. But when you can be allergic but not atopic, this may be a little more confusing for you. But there are instances where, like latex allergy, drug allergy, may not have any sensitization, but you're allergic to it. But if you're allergic, you're always sensitized. So this is a basic allergic mechanism. Very briefly, what happens is the allergen enters through the compromised epithelium way up there, and as immediately it is taken up by a cell called dendritic cell or antigen presenting cell, which is a very intelligent cell. It picks up the antigen, chops it up, and prepares it, and it presents it to the T lymphocyte. And T lymphocyte will, if it recognizes that as foreign and doesn't like it, it will, through the help of interleukins, or these are substances that are produced by these IL-4, IL-13 interleukins, it tells the B cell to produce IgE antibodies against it. These IgE antibodies produced by the B cell floats in the circulation. That is what serum IgE, it is a free IgE, but it also goes and sticks onto the surface of mast cells and basophils, and that is called sensitization. Sticking of the IgE, specific IgE, against the mass on the surface of the mast cell or basophil, that means the person is sensitized. The next time he is exposed to the antigen through the compromised epithelium, it enters. There is no antigen presentation or anything. The second exposure, the mast cell is sitting right there with the specific IgE. Immediately, two IgE molecules catch the antigen, and there's a coupling reaction that takes place, and that what causes the release of all these different substances, and that causes the main thing that is released is histamine, leukotrienes, chymase, tryptase, later on prostaglandins, as well as leukotrienes, and that causes the allergic inflammation. So Very, very important to know. The one cell that is most important here is the T cell. So allergy is a T cell driven disease. If the T cell says, I don't mind you staying here, then the B cell will just produce IgG antibodies. If the T cell says, I don't like you, next time when you come in, I'm going to attack you, the B cell will produce IgE antibodies. And that message to the B cell is given through these IL-4, interleukin 4 and 13 to produce IgE, or if it is producing IL-10, it will only produce IgG. So most of us who do not have allergic phenomena are producing IL-10 and IgG antibodies. We have a lot of IgG antibodies against lots of things. So the reason I'm mentioning this, the laboratories will sell certain tests that they will do IgG RAST for foods. Then you send the blood to them and they will report to you, patient has all these IgG antibodies against milk, wheat, and all that type of stuff. And when you do not know how to interpret it, you will say to the patient, you're allergic, you're producing antibody against all this, so you eliminate all these foods. But fact is, the patient is producing IgG antibodies, which is a normal phenomena. It's not an allergic phenomena. So unfortunately, sometimes if you don't know the mechanism, you can do major damage to the patient and to the family. And this we see. So this is something you need to know. IgG RAST is a useless test. IgE RAST is a useful test. That's what we call now as immunocap. So if you're looking for specific IgE, that is a useful test. A specific IgG is a useless test. So where is all this T cell, B cell interaction taking place? It's actually taking place in your lymphoid tissue, not in your blood. So as soon as the antigen enters through the skin, antigen presenting cell picks them up and through the peripheral lymphatics take them to the regional lymph nodes. If you take a cross section of the lymph node, which you have studied in your MBBS classes, and you have cortex and medulla, and we know that in the medulla, then or in the cortex, you have T cell area, B cell area, there are all these lymphoid follicles. So there's a T cell zone, which is a parafollicular cortex, that is a T cell zone, and there's a B cell zone, which is the primary lymphoid follicles. So this is where the reaction takes place. So it is not unusual for patients with acute allergic reaction to have swollen lymph nodes because the reaction is taking place. They say, my neck hurts also. So you feel the cervical nodes are palpable. It is not infection, it's inflammation. So this is just to briefly mention, allergic reaction, it's not all immediate. There's an early phase and a late phase. An early phase which occurs within the first half an hour, within the hour, and that is due to histamine, kinase, tryptase. The late phase comes 6 to 8 hours later, and that is much stronger due to prostaglandins and leukotrienes, and that is what you treat every day. You are treating asthmatics, allergic rhinitis patients who got significant inflammation, and that is late phase reaction. And late phase reactions respond to steroids. Late phase reaction do not respond to antihistamines. That is why we use inhaled steroids. So when you are using inhaled steroids, what you are doing, you are taking care of the late phase reaction due to allergy in an allergic problem. Now, IgE, if you look at it, the molecular weight is very high, 180,000, very low concentration in normal people. All of us have IgE. Allergic people have more, but it is not specific for allergy. IgE can also be increased in many different conditions. So the marker for allergy is not serum IgE. So do not order total IgE to rule out or rule in allergy. Use always specific IgE, either skin test or immunocap. The important thing about this slide, there is a sentence here. It will not cross the placenta. So when you do have this delivery taking place, people do take cord blood. Cord blood is all coming from the fetus. So when you measure the cord blood, all that blood that is coming from the fetus has specific IgE if the child is already sensitized. Because we know that fetus immune system gets matured by 6 to 8 weeks of gestation. It's able to produce antibodies. It's functioning. So you have a functioning immune system in the fetus at 8 weeks gestation. So if the antigens are going through the placenta to the fetus, then the child has a tendency, the fetus has the capacity to produce IgE, and that IgE can be measured by cord blood. So cord blood IgE is used as a measure to see whether the child has already developed allergy or is prone to develop allergy later. So this is an allergic march, which shows that this march takes place. Initially you can get eczema, then you get food allergy, that followed by asthma, and that followed by allergic rhinitis. So it's like a march. So the reason I am putting this with only one message here, the message is allergy is a progressive disease. That is all I want you to remember. Allergy is a progressive disease. You will not outgrow allergies. You may become less symptomatic, but doesn't mean your everything is gone. So do not tell your patient, oh, you are going to outgrow it, and I'll give you some antihistamines. You will go outgrow it. He will not outgrow it. They may become even asymptomatic, and I can take any asthmatic who is totally asymptomatic and do a methacholine challenge and demonstrate that their airway bronchial hyperactivity is abnormal. So do not tell your patient that you will outgrow allergies. You can say you can get better on your own, but any age it can come back again. So you do not outgrow allergy. I don't know. So with this foundation, let's move on to clinical approach. So just a few general comments on a typical allergic patient. Allergic patient is a confused patient. He is an anxious patient. They did a survey in the United States. They wanted to know how many health providers does an allergic patient will have seen before they come to a specialist. It was a surprising data. They would have seen 12 health providers. Either it's a nurse or a physician or someone else. And they have got different messages from each person. So the patient is confused, anxious. They've also read Google, and that will confuse them more. And so they have many questions. They expect answers. So that is the reason why allergist or a specialist in allergy has to spend more time. General practitioner doesn't have the time. So what he could do is get a very brief history of a few symptoms. And even you can do few skin tests in your office. General practitioners can also do few skin tests. Do not order total IgE. Do not order those panels for obvious reasons I'm going to tell you in a few minutes. But amazing thing about allergic patient is the patient feels, if the tests are positive, he feels good. Oh, I'm allergic. I want to be allergic. What are the three ways of diagnosing allergy? If you can tell me an answer, but because of the setup, I can't ask you any questions now. But the three ways of diagnosing allergy, when I ask people, even physicians, even allergy specialists, they say history, specific IgE, skin testing, lung function, all that. But the real answer is history, history, history. These are the only three. This is the only way for you to make a diagnosis of allergy. Skin testing will only tell you whether they have specific IgE. Okay. Human immunocap will also tell you whether there's a specific IgE. So one is a lab test in vitro, another is a lab test in vivo, but a skin test or immunocap will never tell you whether the patient is allergic. And diagnosis of allergy is made only after you have taken a thorough history. It's a clinical diagnosis. That is what I want you to understand. Clinical diagnosis. It is not a laboratory diagnosis. You can have all the tests normal and still be allergic. So, or you can have all the tests positive and not have allergy. So this is a very confusing type of issue. So you need to have a good training. You should know how to correlate these laboratories with history, and What generally we see, if I see 100 patients in my office, only 40% are allergic enough to be intervened. Intervention is necessary. 60% have a lot of sensitization, do not have correlating symptoms. So only 40% will need something significant treated, like immunotherapy. 60% do not. So I want you to know, just because you do skin test doesn't mean you have all the answers. You need to have a good history. So you should know how to take a good history first. A detailed history is most important, where you have to take what is your complaint, what is happening, let the patient talk, when does this symptom occur, what are the things that makes it better, what are the things that make it worse, that the symptoms occur inside the house, does the symptoms occur outside, does it have a seasonal pattern, what exactly are your symptoms. If you look at it, there are certain symptoms which indicates a mast cell activity. A histamine release will make the patient have itching, vasodilatation that causes swelling and exudation of mucus. So, and the leukotrienes and the prostaglandins causes inflammation or swelling of the tissues. So all these things you have to correlate. So you should have what we call as a thought process. As you are taking the history, you should also be thinking, does this sound like allergy or does not sound like an allergy? This is something that should be occurring with parallel thinking. You can't take a history and start thinking in front of a patient or refer a book. You should be doing it simultaneously. So you need practice for that. A physical exam is sort of useful but limited, because many times allergic patients look good when they come in. So when you look in their ENT exam, they find they have some swollen membranes. The swollen membrane looks a little pale, but there's explanation for all these things. I'll tell you what. And their lungs may be completely clear even with the asthma. Their skin may look normal even with eczema, but history will tell you that they were not normal before. They were not normal a few months ago or a few years ago. So the history has to start not from birth, it has to start from pregnancy. You have to start from pregnancy and then go through to the birth history, the growth history, the child's pediatric history, and adult. Even in an adult, you have to take a pediatric history. And then you have to do correlation. The reason is it's a progressive disease. Now, let's come to a specific case. This is a 6-year-old Arjun presented with itching, nasal congestion, sneezing, blocked nose for last 3 years. His symptoms are every day and they are year-round, mostly indoors, aggravated in late summer, early fall, and again early spring. Occasional nocturnal cough, one episode of wheezing 2 years ago, relieved by nebulization and oral corticosteroids. He also has impaired quality of life. He doesn't like to go to school. He's tired. He cannot sleep well. His academic performance is failing. Parents are very much worried. His lifestyle is impaired. So what are all these things telling you? This is a 6-year-old boy who has got itching, nasal congestion, sneezing, which is indicative of mast cell interaction, mast cell activity. Histamine is the one that causes itching. Histamine is the one that causes mucus production. So he has got sneezing. Itching and sneezing are characteristics of allergy, and mast cell activity or histamine release. Congestion is or stuffiness is a marker, is a signal of inflammation that is due to leukotrienes and prostaglandins. And he has got these symptoms daily, and sometimes more during night or early morning than other times, because there's a variation of a chronobiological phenomena with allergies. It also has aggravation during certain times of the year because of exposure to different pollens and molds that occurs in the summer and again in the spring. And he also has developed nocturnal cough, which is an indicative of lower airway involvement, which means the disease has moved from the upper airway, from the nose and from the eyes and into his lungs. And that is when he starts having coughing. So they have done studies where they have done bronchoalveolar lavage, they have done bronchial hyperreactivity studies, even lot of lung function studies between day and night, and they found that patients have the worst lung functions. They have evidence of significant inflammatory component in their bronchial lavage between 12 midnight and 4 a.m. At 4 a.m., you have the worst lung functions, and at 4 p.m., you have the best lung functions. 4 p.m. is when the patient comes and sees you in your office. 4 a.m., nobody comes to you. So you need to ask what happens at night. How many times do you get up? Do you sleep okay? Do you use your inhaler? So why do you get up? Do you have any difficulty breathing? Do you cough? Does your child cough? Can you hear your child coughing? Patient may not know, but the child, most of the time, parents do not sleep well when the child is coughing. A nocturnal cough is indicative of asthma coming on. Nocturnal cough is indicative of sinus disease. Nocturnal cough is also indicative of gastroesophageal reflux. These are the three things you should always think about when child is coughing. And impaired quality. Now, allergy is not a disease of nose and lungs or for the skin. These interleukins and a lot of these chemical mediators that are produced due to activity. Allergic activity is not like only between 4 and 8 o'clock. It's 24/7, 365, occurring every day, all the time. More during certain times, less during certain times. These interleukins are, these chemical mediators are floating all over. They go to your heart, they go to your brain, they go to your muscles, they go to your skin, all over. So, allergic individuals do not sleep well. Allergic rhinitis patients, 88% of them has what we call as microarousals at least 10 times a night. Their sleep pattern is impaired. So when you don't sleep well, you're tired in the morning. And many of these patients go to sleep at 9 o'clock in the morning. They feel drowsy. They don't concentrate on their studies or work. So there is a huge impaired quality of life in allergic patients, both in young people and older people. You may not die because of this particular allergic problem, but it may not be worth living having allergies like this. So when you look at his environmental control, there are no pets, ventilation is poor, housing condition is a little damp. Most of the Indian houses are damp because of the water leak, because of the construction and rain. So what does dampness do? It promotes mold growth. Mold growth, whether you have allergies or not, or have an adverse effect on respiratory tract. So when you look at when you enter your own house or anybody's house, look at the walls. Don't keep on looking at TVs and all that. Look at the walls, look at the roof, be observant. See if you see discoloration, and that means it's mold growth. If you can smell molds, that means there's a plenty of molds. Okay. And family history is very important, especially if the mom has asthma. Maternal allergic history is much more important for us. So if one parent has allergies, chances of the allergies being transmitted is about 50%. If both parents have it, 75%. If both parents do not have allergy, still 25%. So on physical exam, they found his nasal mucous membrane was pale, boggy, tonsillar hypertrophy, cervical nodes palpable, clear lung fields, no wheeze, nothing, skin clear. So the reason why it is pale, boggy, we know it's highly vascular, but still pale. Why? Because the membrane has thickened. Because of constant inflammation, continuous inflammation, the basement membrane is thickened. And that's why it looks pale and boggy. And whenever there is tissue damage, whenever there is inflammation, you need to know repair occurs at the same time. Damage and repairs occurs at the same time. Like Indian road or even roads here. When there is damage, they put the paving and they get better. And again, there is damage and repair. And the road gets bumpy. And that is what remodeling is. When you look at remodeling airways, when you look in the nose of a normal, perfectly normal individual, mucous membrane looks pink, shiny, and smooth. If you look at a nose of inside the nose of an allergic individual, it looks pale, boggy, mottled, irregular. That is airway remodeling. So we consider nose as the mirror of the lungs. Whatever you see in the nose is occurring in your lungs. So you need to pay attention. I don't know how many people look in the nose. You always look in the throat, but you don't look in the nose. Less than 5% of you look inside the nose. From tomorrow, you start looking inside not look at the nose, look inside the nose. And once you get used to it, patient get used to it, and that is more of a thorough exam. Now, thought process. With this history, with this type of information I had, I know there is some sort of a mast cell activity. I know there is some sort of an inflammation. I also know there is upper airway, lower airway involvement. And I also know one very important thing, the disease has progressed from upper airway to lower airway. So this is a progressive disease. And the symptoms are nocturnal. They are not localized. They are systemic. He is having symptoms. He's feeling tired. His sleep pattern is bad. His learning ability is impaired. So this is a systemic disease. Allergy is not just a localized disease. It is a disease from head to toe. So this is how you need to be looking at patients with allergy, is look at them locally, think systemic. All. So this is a systemic disease. So what are the signs? And also this is showing chest involvement. So asthma, physical exam, maybe. So how do you know a disease is progressive? You can get an idea of disease progression just talking to the patient. You may not see the progression, you may not feel the progression, but you can imagine the progression by just taking good history. When the mother says, whatever medication you gave me last time is working, but when I miss the medications, the symptoms come back. That is a sign of progression. When, in spite of giving the medication, the child is better than before, but the child is having some more coughing at night or having some more congestion. Or when I miss one dose of the medication, he has significant symptoms. He did very well for the first 2 months, and after that, he started having a little more symptoms, but I am still happy compared to. And he's having increasing symptoms at night. So all these subtle points that you find out when you take a history is a sign of progression. So this is what we call as clinical progression. What we have found in our practices is we do skin testing on children every 6 months, a few skin tests to see if there's immunological progression. We find allergic children not only have clinical progression, but they also have immunological progression. That is a dust mite reaction, for example, which was 6 by 8 millimeters in diameter 6 months ago, has become 10 to 12 millimeters, 10 by 10 into 12 millimeters in diameter. That means the size has increased, and that is called immunological progression. If you look at the specific IgE, the titers have increased. That's immunological progression. So when you have clinical progression, many times you have immunological progression. Plus, there are new skin testing that are new antigen allergens that are also getting sensitized, and that is also immunological progression. So when such things are happening, you need to think about allergen immunotherapy. So always take a good history, detail. You should always have a reason to ask a question. Try to correlate between those two. Always look for progression. Now in this patient, will allergy skin test be useful? Yes. Spirometry pre and post bronchodilator? Yes. Total serum IgE? Totally useless. You should not do total IgE in anybody. You do total serum IgE in patients whom you suspect ABPA. You do total serum IgE when you want to do therapy with anti-IgEs, omalizumab, but not to rule out allergy or rule in allergy. Never do total IgE. It's a total waste. It's expensive. And would you do a nasal smear for eosinophils? No. Immunocap is an excellent test. But will you do immunocap on a routine basis because these laboratories will come and sell you all these different panels? Don't. Never do panels. Take a good history, and based upon the history, you determine what should be tested. But it is better for you to do a few skin tests because it's 10 times less expensive. What is the other advantage of skin testing? Skin testing is a very, very useful test. It's more than 100 years old, but still the gold standard for allergic confirmation or sensitization, confirming sensitization. It's a very easily test done, well tolerated. You just have to do 2 skin tests, just a prick, and the fear is gone, and then you can do a few more. It's safe, reliable, sensitive, 80% correlation, affordable, clinically relevant. The last thing is the most important, clinically relevant. prick skin testing is much more clinically relevant than immunocap. With immunocap, what you're measuring is the serum IgE, specific IgE floating in the serum. With skin testing, what you're doing is a quantitative measurement of the IgE, which is bound to the mast cell or the basophil, and that is what in nature what happens. So, skin testing is more natural. And when you have a reaction on the skin, and you share it with the mom, see your son is reacting, and that's what's exactly happening inside the respiratory tract. You're seeing the swelling and the redness on the skin. Then this is what exactly happens in the nose and the lungs. It's a wound. It's a wound. Inflammation is wound. And what does it respond to? Anti-inflammatory agents. And that gives you better compliance with therapy. Mom is convinced, yes, my son has wound in his lungs and nose, so I should use inhaled steroids even when he is feeling okay. So this is how you get compliance. And this is what a skin test shows. We always use control, saline and histamine to make sure to look at the baseline reactivity and what happens if you have a histamine release already there. So we make sure we use histamine to make sure there is no antihistamines taken which interferes. So a positive skin test is 3 millimeters of wheal above the negative control. You go ahead, prepare the skin, cleanse the skin, put these drops, prick it, wait 15 minutes, and then you will see the reaction. I'm not going to go through technical thing here because we don't have time for all that. This is how a positive skin the test's results are shown. So always when you when you look at skin test results, you should look at two things: one, negative control, positive control. A negative control means a baseline reactivity. A positive control, histamine, tells you there's no interference, and based on that you interpret it. So can you skin test a child? Definitely. We skin test a child after 6 months of age. How many will tests will you do? There's nothing like a regular number. In a small child, even 3-4 skin tests is enough for us to know. You just need one positive skin test to infer that specific IgE is being produced. The immune system is already producing allergic antibodies. You don't need 25 skin tests to tell you that. We did a survey several years ago of 2,000 charts and found 10 antigens will pick up 80% of the sensitization. So you don't need too many skin tests. If you want to do a basic screen, 10 skin tests, which includes a couple of inhalants, the controls, and the 2 foods, is enough for a child. If you want to do a basic screen on an adult, 15 to 20 is enough to know that. So after you do the skin test, will you treat the skin test? No, you treat the patient. You have to treat the patient. You have to correlate the skin test results with the patient's symptom. That's very important. Whereas an immunocap or the blood test is a very good test, 80% correlation, but it has got more false positives, very high sensitivity. That's why little more false positives, more expensive, 10 times more expensive, false positives. Correlates also well, not interfered. But what you are measuring with the immunocap is free IgE, not bound IgE. So this is a spirometry. I don't want to get into detail. It's a fantastic test to know whether there is obstruction, reversible airway obstruction. But point is, you can have a normal spirometry in the presence of asthma. Now, different antigens which are most important are indoor antigens. Sorry. There's one slide missing there. Okay. Major environmental allergens indoor are dust mite, cockroach, cat and dog, mouse and rat, mold. The dust mite is the most important. In India, 80% of the people react to dust mite. They are sensitized. Cockroach is another major one. Dust mite, cockroach, and a mold called Alternaria. These are the only 3 things that cause asthma to a significant extent. Not the pollens. Pollens do, but not much. Why? Pollens do not reach the lungs. The diameter of a pollen is anywhere between 30 to 40 millimicrons, whereas to reach the airways, it only reaches the airways when it is like 7 to 10 microns, which cat and dog can do that. And dust mite antigen, especially the powder that comes out, can also reach the lungs. So dust mite is a thing that is a major antigen, It is present right. Dust mite is present right in your bed, in your sofa, in the carpet, and it is quite active at night. When you're sleeping, the dust mite is actively having dinner. What is the food for the dust mite is your own, the skin, scales of your skin, and it needs moisture, and that is provided by your body, the humidity. So you provide the heat, you provide the water, you provide the food. And because we undergo what we call as epidermal mitosis, we all shed skin. We all, every day you look in your mirror, in your, you look at your skin, in your face at your mirror. Oh yeah, I look okay, because you shed your skin last night. It's not just the snakes that shed the skin, you also shed the skin. We all shed skin. And these stratum corneum, these scaly scales is the food for the dust mite. It goes through the holes in your bed sheets or in your pillow cover, and that is how the dust mite is present in the foam. They don't come and crawl on your body or in your skin. These particles, microscopic particles, go through the holes in the through those bed sheets and through the cloth. And that is why when we do dust mite controls, we tell patients to take off all these bed sheets, pillow cover, and boil it every week. Yes, put it in real hot water for 15-20 minutes, or real hot water. What do you mean by 55 degrees hotter? Is you touch the water, you don't want to touch it again. That's 55 degrees centigrade. You don't want to go measure with the thermometer. So that is what a hot water is. You don't want to touch again, and that will kill the dust mite, the remove all the dust mite as well as clear the holes. But the best way is to get one of those encasings which prevents the particles from getting in and out of this. Cockroach is another major thing. Cockroach causes a lot of asthma and allergies, major. So it's very, very important not to eat when you are having in your bedroom. Nowadays, it's all lifestyle. People have too many TVs. People are hooked on to TVs when they're having dinner. They're looking at the TV, they don't look at the food. So they are just putting all this food in their mouth without even knowing what they're eating. And small, small food particles fall on the ground. After you eat, you just clean up the table. You don't clean the floor. So you go to bed. So 1 a.m. or 2 a.m., that is when the cockroach come out with their proboscis. They know you're got sleeping. You're not studying. You're all sleeping. Place is quiet. Cockroaches come. They eat the food particles and they shit. And it is the antigen, cockroach antigen is present in the shit. And when you see a cockroach, what happens is you go and hit the cockroach, you kill the cockroach, and you spread all these GI tract and the fecal and the fecal matter and the body particles all over. So you spread the cockroach antigen all over, and you think you have done a very good job, but what you have done is a really bad job by spreading the cockroach antigen. And the maid comes in the morning and grooms and brooms on the floor. What she's doing, she's spreading the cockroach antigen all over the place. So it's very smart for you not to kill the cockroach, not to eat, not to watch TV and all that when you are eating. And the best way to eat is eat in your kitchen. Now, with a dining table coming, that has caused more cockroach infestations. And also, we used to clean whenever we used to eat on the floor. We clean the with very thoroughly, but not the table, and that also has caused more food allergies. And the thing is, by cockroach elimination, by pest control, it has been shown that you can reduce the seriousness of asthma, the morbidity, as well as hospitalization of asthma. Dust mite control also does the same thing. So I won't get into too many details about all the other stuff, and I'm going to stop pretty soon. So success of allergen immunotherapy, if you decide, it all depends upon, very, very important is patient selection. It should be a young patient with a young disease, with a young remodeling. They are the people, they are the persons who will respond to allergen immunotherapy very, very well. Older people, patients who are more than 50 years old, comorbid conditions, onset of COPD, huge amount of remodeling, do not qualify very well for allergen immunotherapy. Allergy immunotherapy is now is given sublingually, subcutaneously. Subcutaneous is what we were all trained, and sublingual is very popular, although still not approved by the drug council. It works well. It takes 2 years for the sublingual to work well. And after 3 years of immunotherapy, you can actually 3 to 5 years of immunotherapy, you can stop it and it'll still do well. It's because it's working on the T cell. The immunotherapy works on the T cell. When the T cell is trained, it will continue to function properly and produces a non-allergic environment, non-allergic Th1 environment, in spite of not even taking the allergy drops or shots, but it takes time. So you have to use proper antigens, good quality antigens. So this is the function of the allergist. As a general practitioner, when will you refer the patient to an allergy doctor? When you have a strong history and you have tried pharmacotherapy and the disease is still progressive, refer the patient. That means patient is getting better but not totally. That means there's a clinical progression, immunological progression. This is a time for you to refer. And you can actually institute environmental control as a family practitioner. You can also do a few skin tests as a family practitioner. In the US, we teach the family practitioners how to do few skin tests. In the India, we have all these different workshops, pre-conference workshops, where we teach you skin testing. Also, we have many courses from Bangalore to Medtrain, what they call MEDTRAIN. Through we have many courses across India. We have courses that give you postgraduate diploma, and there are courses where it is easy to enter for family doctors called allergy asthma specialist course, where they teach you how to do skin testing, how to take a proper history. And these are things that you should pursue only if you're interested. So I'm going to stop here. I'm going to, and the summary slide, last slide, is allergies are common. Comprehensive history is the most important. You try to correlate skin test with history. Treat the patient, not just the skin test. Anti-allergic medications are effective, but they do not modify the disease. The disease is still progressive even when you give medications, because the progression, because allergic disease is a T cell driven disease. So men know there's no medications that work on the T cell except allergen immunotherapy is the only modality that works on the T cell. Only disease that is disease modifying. Now, you can answer these questions. I don't know how you do it. Yeah, the organizers know. You can answer yes or no to these following statements. Allergies are rare. Yes or no? Please go ahead and mark it. Okay. Very good. Can you take off that thing? I have to read the next one. Total
Yes.
IgE is the best test to diagnose allergy. Yes or no? Good. Move on. Allergy is a progressive disease. Yes or no? Yes. Good. Allergy skin test is a very sensitive test. Yes, good. Allergen immunotherapy is highly effective. Yes or no? Good. Correct. Children outgrow allergies. Yes or no? Hmm. They do not actually. The answer here is a little bit of a problem. They do not outgrow. Allergy is totally curable. Yes or no? Correct. You can't cure it, you can control it. Okay. I think what should we do? We should go for some more questions. Chat box. I don't know where is the chat box. How common is allergy contributing to etiology of pediatric asthma? 80% of pediatric asthma is allergy induced. It's very common. So 80% is allergy induced. So pediatricians have a huge role in doing allergy testing as well as instituting proper environmental control and possible immunotherapy. And what has been shown is if you institute allergen immunotherapy and other measures environmental control early enough, the progression of the disease is actually stopped. It has also been shown actually you can prevent asthma from developing. The odds ratio of preventing asthma developing is 2.5 times compared to with immunotherapy compared to no immunotherapy. So the allergen immunotherapy plays a big role in preventing the development of asthma in children if you institute it early enough. How common, how are allergies common in HIV? I have no idea. PL HIV means what is that compared to HIV? So that is positive HIV. HIV is a immunological disorder. We generally do not go and test for allergies in immunodeficient patients. And if the T cells are short, then probably it's not working well and it could be low in those patients. I'm just guessing. I don't know. Histoglobin role, it has been used quite extensively and it's not that much used anymore. I don't have any personal experience using it. And it is, since we have much better type of asthma allergy control now, I don't think it is an indication for us to go back to histoglobin, which is very old way of treatment. So we have much better way, much more scientific way, much more evidence based way of handling the disease. Kindly elaborate mode of action of mast cell stabilize. You know what? It is a very, very interesting type of medications, especially chromoline sodium, ketotifen. What it does, it stabilizes the mast cell membrane. And although the IgE binding has taken place, so IgE has bound to the antigen, coupling reaction has taken place, the release, because something to do with the calcium release, calcium influx, the release of the mediators or like histamine, chymase, tryptase are inhibited by these mast cell stabilizers. Most one I have much more experience is chromoline sodium, and now people also have experience with ketotifen. Yes, very insightful session. Thank you. So if the patient comes first time, with breathing problem, you have to first take a proper history and treat them. Treat the disease. First, make the patient comfortable. You don't go and check for whether allergic to dust and pollens and all that. What is the problem? Is the patient having bronchospasm? Patient is in trouble. Go ahead and treat the patient first. Once the patient is stable, you might treat them quite vigorously also, not only with nebulization, even with steroids you might have to treat depending upon the clinical situation. And then it is very common for patients with asthma. If you take a little bit history, even if you spend 5 minutes, you will know it is asthma, because a lot of times it's a recurrent problem. It is not a one time problem, it has occurred before. And many times it is just unexplained cough is actually asthma. Unexplained cough, patient says, I got a cold, my brother got better in 1 week, but for me I kept on coughing for the next 1 month or 1.5 months. That is indicative of asthma. Indicative of asthma. Post-viral cough is indicative of inflammatory component, post-viral inflammation. Or bronchiolitis in very young child, recurrent bronchiolitis is a predetermined cause for asthma development. So these are things you need to be aware of. Are there any blood tests to detect? Yes, I just told you. Immunocap is present. You can detect specific IgE antibodies. The only difference is you are measuring the floating IgE, which is present in the serum, not the bound IgE, which is the natural way. So if you are up against the wall, say like you don't have a good skin testing material, or you cannot do skin testing because the patient has taken antihistamine, or you cannot do anti skin testing because the eczema is so extensive and so severe, or if it is a very young child below 6 months of age, or a very old person with very frail skin, and you want to do, then you could do a skin test, blood test for with specific IgE. There's nothing wrong in it, but you have to have at least some basic history to justify why you are doing the specific IgE. They do not use panels. Do not use just panels which have nothing to do with the patient's history. Indications not a patient depends, like it's probably the best drug. Steroid nasal spray, if the patient is clinically having allergic rhinitis or allergic asthma, it is the best drug. Inhaled steroids are the best drug. It reduces the inflammation, reduces the overall allergic inflammation, and in all by also improves the patency, improves the quality of life. So it's one of the best drugs, but still it won't work on the T cell. So the disease will still progress in spite of using inhaled steroids. Inhaled steroids will give you a very good relief for the patient, but it will not stop the disease process. The disease progression will still continue. And you can use steroid nose sprays continuously for months and months without being worried about too many side effects, especially mometazone preparations. And you don't have to use full dose all the time. Many times we just get it under control within a month, then reduce the dose once a day or every other day. That's enough. It will still do a good job. So you have to always what we call as a tailor make the dosages of the steroids. There's nothing like the same disease is occurring at the same extent in everybody. Everybody's disease is different. In one person, disease can be different at different times. So actually, if you want to use the medicine, anti-allergic medicine, or you want to cut down on the allergic medication, you can cut down the daytime medication, but not the nighttime. You always should continue the nighttime medication or the evening medication because it's a nighttime disease. Allergy is not a daytime disease. Which steroids we can use? You mean if it is an inhaled steroid? No, mometasone is perfectly fine. If you are because if you are using inhaled steroids, all inhaled steroids are same. If asthma, beclomethasone is what you can use quite well. You don't have to go to very expensive steroids, because what the steroids do is the half-life is very short, and the amount of steroids that go into your lung or in your systemic circulation is extremely small. Although they are potent, if they are by their biological nature could be more potent, by their biological availability is bioavailability is quite limited as far as the systemic side effect goes. In case of inhaled steroids, it doesn't get into your systemic circulation, cause adrenal suppression. But it always makes sense for you, if the patient is needing inhaled steroids all the time and the patient mother is happy, they're comfortable, doesn't mean you have answered, you have taken care of the problem. You have just controlled the symptoms. You should do skin test, you should do environmental control, you should also consider allergy immunotherapy, because these are the three things that will help you to give something specific than just controlling symptoms. Vitamin A, B, C, D, E are good in, they say D is not a bad one to take, because there are many vitamin D deficiency patients are more prone to develop allergy, but it is not like it is a cut and dry type of indication. And none of the other vitamins play any major role in preventing or getting relief in allergic patients, because the mechanism is very, very different. They won't do any harm, but also at the same time, they won't do very much great good.
That would be our last question, sir. Thank you so much
Okay.
for such an
Are we
insightful
done?
talk. Yes, sir.
Okay, good. Nice crowd. I saw a lot of them answered the quiz very well. Good questions. I hope this session was useful in your clinical practice. I thank, is it Medflix, for arranging this particular presentation. Can I go now?
Yes, sir.
Thank you
Thank you
very much.
so much, sir,
Your,
for
your
such
name is
a wonderful
Rita?
talk.
Thank you. Bye bye.
So, bye, sir.
Yes.
Bye.
Bye bye.